Hi, I'm Dr. Kotecha from the Kotecha GPS Club, and today I'm have the pleasure of talking with Dr. Ian Furst. We're going to talk about aerosols. Dr. Ian Furst is an oral maxillofacial surgeon in the Cambridge area. He's also the CEO of the Swiss Cross Foundation, which does work with the International Red Cross in humanitarian missions around the world. Welcome, Ian. Thank you for joining me.
Glad to be here.
I've known Ian since I started where I've practiced for the last 15 years. So I'm glad that he took the time to talk about something that has become quite important in dentistry in the last few months, aerosols. So today, basically what I'm going to do is I'm going to go through a couple different areas of aerosols. We're going to talk about them in terms of defining them, talking about viruses and bacteria in them, and then we're going to kind of go through some of the practical applications that dentists have available to them to decrease that, which in turn will decrease the risk to themselves, their team, and their patients. So once again, welcome, Ian. Thank you very much. We appreciate this.
No problem.
So the first thing we're going to talk about is aerosols, and I've read a lot about them in the last couple weeks. They've been there for our whole career. Why are they becoming so important now?
Oh, okay. Well, I mean, they've been there our whole career and they're becoming important now, obviously, because of COVID. And what is the risk of us being either infected by the aerosol in a person that happens to have COVID, or the risk of us transmitting it to our next patient where we haven't properly dealt with the aerosol? Mm-hmm. They have been there our whole lives, but there's not a lot of research that's been done on them. We've looked at where they spread contaminant like bacteria. We have looked at a little bit as to whether or not they spread virus. But the real problem is it's tough to spread, or it's tough to sample virus out of the air. Mm-hmm. So we haven't looked at that really hard. We've been able to find one paper looking at the chances of, say, influenza being transmitted through aerosol. And we do know that dentists have a higher rate of having influenza, for instance, right? But it's never been attributed to aerosol, right? The interesting part of that study, though, it came from 1996, which was back when half the people wore masks and half didn't. And what they found is the chances of you getting influenza were higher than the general population, but no different whether you wore a mask or not, which certainly leads credence to this aerosol problem. My personal opinion on it is I think we're going to see a shift. When I started out in all this, I was a dental assistant in the pre-glove era. And at that time, we had this background noise of hepatitis B that we never really thought about. It was kind of a chronic condition. We knew that it was out there. 15% or so of dentists had it. And it was just considered one of the hazards of working. And then HIV came along, which was the real problem. And that's what caused the change in practice. It wasn't the hepatitis B, it was HIV. So all of a sudden we made the shift to changing gloves. I'm wondering whether or not we're going to see the same shift here, where COVID is what precipitates the change. Mm-hmm. But the real question for us is going to be all the other respiratory viral diseases that we need to prevent.
It's definitely stuff that's changing how we think. So you talked about that study and other studies that have come along that say viruses and bacteria can be aerosolized. You said something there that made me think that dentists have a higher rate of the flu, but have we had large outbreaks in dental offices due to aerosols that you know of? Have we seen any communication between dentists, their patients, and their teams, or is that something we haven't tracked or even looked at?
Short answer is, to the best of my knowledge, and let me preface all of this with I'm not a virologist or an occupational hygienist. This is just my understanding of it, but I will say we've been looking pretty tough at this for the past month. Number one, I don't know of any large outbreaks, but we haven't really looked hard at this either. So the one study that we've been able to find, kind of looking at what our antibody rates are, looked, I believe, at RSV and influenza, and found in a match case control that they were equal, or sorry, they were higher than the normal population. We haven't looked at this with COVID in the dental community, but this is the kicker. During SARS, during MERS, and during the early parts of COVID, we know that these aerosol generating medical procedures like intubation, CPR, stuff like that, definitely increases the rate in healthcare workers that don't have on proper PPE. The flip side to that is that when people do wear PPE, it doesn't change it. So if the core question is, why haven't we seen this before? It may just be that we haven't looked for it when it's mild disease, and when it's severe disease, the patients are hospitalized or symptomatic, and we're just not in that group that's going to be exposed.
Interesting. So now that we have kind of defined that we have these aerosols, let's talk about, the examples you gave. Let's talk about the makeup of some of these aerosols. Do they know if during these aerosol creations, if it's viral RNA that's in there, or is it the protein coat, or is it actually both? And is this enough of a concern? I'm talking as a wet dentist. I'm working on right behind me. That's what I want to know. What is your opinion on that?
Sure. The short answer to that with dental AGPs is we don't really know yet. So then we got to get into a little bit of the technical discussion about, what's being put out there. So the COVID virus is encapsulated. It's relatively fragile, we know. So most decontaminants can take it down. The question becomes, does it live in small droplets or droplets that can stay airborne or stay aerosolized for quite a while? So there was one study that was done that was published in the New England Journal called by this guy named Van Dormelen. What they did was they aerosolized a perfect aerosol, created 5-micron droplets that had virus in them. And what they found is that viable virus was detectable for the duration of the experiment, which was 3 hours. And they calculated that the half-life of the virus in aerosol was somewhere around 6 to 9 hours. The question becomes, though, is that what we have in dentistry? So again, we don't really know exactly the size of all the droplets we got. Apparently, there's some research coming out of the Department of National Defense soon that's going to answer some of these questions. We do know that when patients cough, either with just a normal cough or with influenza, there is definitely virus in those droplets, and it's in the 4 to 10 micron range. And to put that in perspective, when we create an aerosol plume, you're throwing out droplets of various sizes. 100 micron droplet will fall to the 3-meter ground in 10 seconds. But a 5 micron or a 10 micron droplet will stay in the air for hours, right? We know that the virus, at least in influenza, is carried in those small droplets. Predominantly, like 65% of the virus is carried in sub 10 micron droplets. So there's every reason to believe that if you go in and you aerosolize, big and small droplets, that most of the evidence is pointing that it's going to be in all of those droplets, and the small ones will stay airborne for a while.
Yeah. So a follow up to that for me is, so I know it's in these droplets. Is that enough of a viral load to at least put me, my team, my patients, the next patient at risk for transmission?
Again, the short answer,
long answer.
we don't know. So the way they define this is called the human infectious dose 50, the HID 50. And what the HID 50 does is it says, what's the dose required to infect 50% of the population? Or 50% of those exposed, I should say. So we don't know the HID 50 for COVID yet, right? But let's look at how they acquired that for, say, something like influenza. Well, the reason that we know what it is for influenza is that back in the 60s, they took a bunch of volunteers who were inmates down to Fort Detrick, Maryland. Yeah. So they took them down to the Biowarfare Center at Fort Detrick, and they infected all of them with various doses of influenza. To try and figure out who got sick. Now, that's obviously not an experiment we can replicate.
Oh, not at all.
Probably couldn't have replicated back then, but we can't do it now. So if we can assume that the virus is in all of the droplets, and we can also make reasonable assumptions that viable virus is in the sub 5 micron size, sub 10 micron droplets, the question is there enough of those in the air to infect me, my staff, or to fall on the surfaces and contaminate the next person when they touch it? And the answer is we just don't know yet. I think we can make some reasonable assumptions that because we're not seeing a lot of transmission beyond the 2-meter range, it's probably not, a highly transmissible virus when it's in aerosol. So either it dilutes out quickly or you need quite a dose to get it. But the short answer is we don't know.
Yeah.
I've heard a lot of people saying that because it's not airborne, why do we need to know in dentistry? And the short answer to that one is because we don't know when we create the aerosol what volume of viruses we're putting in the air. Whereas somebody sneezes, we know based on experimentation in this case that beyond 2 meters, we're not getting enough of a dose. We have no idea what that dose will be in dentistry.
Okay. So you've answered some of my follow-up questions, but I'm going to switch a little bit. So if we know that we cause aerosols when we do certain procedures in dentistry, I've seen guidelines from other parts of the world. Ontario, where I practice, doesn't have them out yet. What's in terms of when they talk about a PreMouth Rinse, is that really decreasing the viral load, like the 1% hydrogen peroxide or the IO rinse I've seen? Do you think they'll help us as dentists? Like, is that something you see going forward for a period of time?
Yeah, I think I think that if you have enough community transmission and you need to make reasonable assumptions that somebody in your chair has a respiratory illness that's carried in the saliva,
Yeah.
it's a good idea. Again, we don't know exactly. They haven't done viral studies looking at the rinses, but we know bacterial studies, it takes the viral or the bacterial load down 80 to 90%, somewhere in that range. And the virus is much more susceptible to it. So we think that it'll decrease the viral load. The only qualifier to that is we're not sure how long it lasts. I've seen estimates on 30 minutes and enough saliva is produced that the viral load climbs back up again. So it may be one of these things where, yeah, you rinse, but if you're going to be doing an hour-long procedure, you stop halfway through and have them rinse again.
Interesting, more stuff for us to do. So now that we talk about aerosols and being in the air, because that's basically the biggest problem for us as dentists, we're going to talk about some things about air quality that are currently in your office and the exchange of air through your HVAC system and other stuff. Now, I've read and I've heard and I've seen guidelines that talk about air exchange in your operatories. I've had it talked to me by industry people. I've had conversations amongst me and my other colleagues that at first, a lot of us didn't even understand it. So I had it measured. And so we're going to talk about something called air exchange, and ACH is the number we're looking for. So as dentists, we're not engineers. What does that actually mean, ACH? Like, I've had it tested, and I would advise every dentist that if you should have it tested, because you should know, because that can affect how long you can leave your operatory between patients. First thing I would tell everyone to do is reach out to your landlord. They may have somebody who does do the testing. My landlord did not. I ended up calling the person who designed my office, and they put me in touch with a mechanical engineer who then referred me to his air balancer, and I had them come out and test all my operatories. So that's, and the third one is, if you don't know anyone, start looking for an air balancing company, because they're going to be out there giving this kind of information. So I'll back up a bit. I went on a little tangent, but let's talk about ACH. What does that matter? Like, from a dental
Sure. Well, just out of interest, Shamek, where did your ACHs come in? What was the final value for you in the various rooms? Like, what was the range?
They ranged anywhere from 6. In my one, I have 2 offices. My older office from 6 to 8, and my newer office was 17 to 18. And the guy went to both offices. He's like, if I was you, I'd go to the second office and work. And
So,
I've added some equipment. We'll talk about that later, but go ahead.
all right. So number one, for those that are just learning about this, the air changes per hour is how many times the air in a particular room is turned over. And it's important because if you have an aerosol in the room that's got something that's a pathogen in it, you need to wait until you've removed or diluted out most of that, either with fresh air or by just moving it out of the building completely. In the hospital, we have negative pressure rooms. And in those negative pressure rooms, there's very, very strict standards on this. They need to have 12 air changes per hour as a minimum. They need to have a certain amount of fresh air pumped in with it, like 3 air changes per hour need to be fresh air rather than recirculated and all the rest of it. but it's all about dilution of whatever the pathogen is. So when these droplets come out, and we talked about this already, that you had the different sizes, they're going to do one of two things. The ones that are under 20, it's not a hard number, it's all on a scale, right? But the ones that are over, say, 20 microns or so are going to settle down to the ground pretty quickly, but the other ones will stay in aerosol. Then what you need to do is the settled ones will happen in a reasonable amount of time, but how long does it take to move all the rest of this out? If you look at how much cubic feet per minute is being moved in and out of the room, let's say it's 150 cubic feet per minute, and then you look at the size of your room, length times width times height, that's a certain amount of cubic feet, right? So you take your CFM, or the cubic feet per minute, you multiply it by 60, and you might have 10,000 cubic feet per minute, or sorry, per hour of air movement, and your room is 1,000 cubic feet. You've got 10 air changes every hour. So that's the air changes per hour. There's no strict guidelines on how this would work normally, but the Center for the Disease Control offers some estimates on, and it's just a pure mathematics thing about if you have any aerosol in a volume of space, how is that aerosol recirculated? And it's just a mathematical formula: concentration 1 minus concentration 2, bunch of logarithmic or logarithmic formulas in it, or lawns in it. And you get to around 12 air changes per hour, means that you'll be about 35 minutes. You've removed 99.9% of whatever the aerosol was. So for you, Shamek, you're sitting pretty, because 17 air changes per hour, I mean, you'll be 25 minutes, you'll have changed over the room to 99.9%. Whereas if you've got 6, you might be over 100 minutes,
Yeah.
you know?
So that's where I'm going to go next. So when I heard those numbers, I got on the phone to various different people that I know, including some of your colleagues, and I purchased external auxiliary air filters for my offices. And I know that it increases, so from a practical point, this is what I want to know. So I buy one of these machines, and I know my ACH. How does that, do you just add the numbers together if you know how quickly, or is it more complicated than that?
So there's two pieces to this: the regulatory side, and then the engineering side.
Yeah.
On the engineering side, is absolutely more complicated than that,
Okay.
because you don't know, where is that air cleaner sucking air in, where is it moving it out, how is it impacting the airflow in the room, and in particular, if the aerosol is being generated at the head of a chair and your air cleaner is at the foot of the patient, is it bringing that aerosol down and moving it out, and the rest of it. Then there's the regulatory side of it. So the Ministry of Health did a study on air cleaner purifier, or air cleaners, after 2005. I guess it was the H5N1 crisis. And in their document, they basically say it's additive. So they're just taking the two CFM. So if you've got 150 CFM from your HVAC and 150 or 400 CFM from an air cleaner, they're making them additive. We don't yet know how our particular regulator is going to account for them. I would imagine at some point they're going to give us some guidance on that. My suspicion is that they'll take it as additive, but they're also probably then going to set that limit at 99.9% to add a buffer in there. Yeah. In the Secretariat's review that I just talked about, they talked in there about a 20% buffer on it. And I think that was to account for the weirdness that happens with airflow and all the rest of it.
So an extrapolation to that is, and I've had many of these discussions with my colleagues that are friends of mine, and they'll debate, say it's not worth buying unit X because it costs so much money. They're rather going to go through unit Y because you can buy it at a big box store for a quarter of the price. So I'm going to ask you point blank, what do you think, what should me go look for when I'm buying one of these? Like, and I'm talking about the HEPA filter, the filtration systems, they have a HEPA filter in them. Mine have a carbon and a UV as well. I've had a surgically clean air unit in my office because I wasn't happy with the quality of air, not because I had any scientific data. I just didn't feel great at the end of the day. So for me, I just put one of those in, and I noticed the air quality change later in the day. but I have one of the big units for my whole office, but I'm going to add, I have already added smaller units. So what I want to know is, can you buy the one at Costco that's a $99, or do you have to go and get a medical grade one? What are you looking for? What CFMs are you asking for? What, like, those are things that I want to know.
Yeah, so I'll be honest with you. This is getting a little out of my area of what I know well. I will tell you what we looked for in our office was that number one, we wanted to make sure that it had an adequate CFM to be additive, to be meaningful additive. So if we had, say, 140, 150 CFM, we wanted to make sure that it was going up to 400 CFM, 200 CFM, so it had a meaningful impact on our fallow times. We wanted to make sure that it had a pre-filter so that we weren't constantly losing efficiency. We wanted to make sure that it had a decent HEPA filter in it. We also wanted to make sure that these things were they could be easily maintained. The part of this that nobody's talking about yet is that think of this like your sterilizer, where you need to have a log on it that shows when you've maintained it. When have you changed the sterilant in it? When have you changed the gasket on it? How has it been maintained? And the same thing is going to apply to these, I think. When you buy one, it's not enough, I don't think, to just pull it out of your basement, because we know the efficiency of these things drops quickly. So you can flip it up to the high setting. You think you're getting 400 CFM, but because it's clogged with a bunch of gunk, you're really only getting 150 CFM or 100 CFM or something like that. For me, sorry, go ahead.
No, you go ahead.
So the big thing for me was, okay, how do we maintain this thing? Are we sure we're going to be able to get filters for them? Are we going to be able to get them accessible? And are we going to be able to maintain it in a meaningful way? And we're going to create a log for it, is the short answer. As far as the UV light stuff, UV light is a really complicated piece of it. I'm not sure how much it helps in a portable air cleaner. I don't think it'll hurt.
I've seen them in the Vita Shield units where you can put them in your lights where it suctions the air above it. And I've seen some people put those in. I mean, you can go put, there's so many options of what you can put in. I think that's part of the problem. We don't know what we can buy.
I had a friend of mine looking at a $200,000 UV light solution. And the problem with it was that it was in the HVAC, which is good because you're going to decontaminate it when it arrives. There's not a lot of studies on it. The air cleaner technology report from the Secretariat from MOL, they showed that they couldn't find any meaningful benefit to it. So, and they reviewed in quite a bit of detail whether or not it was worthwhile having it on there. And they didn't seem to think that it was worthwhile adding on at that time. I've seen some studies where it looks at, say, BCG bacteria, right, where you've got the UV ceiling mounted UV light. Does that help? Now, it definitely would kill off this bacteria well, but it's going to come with risk to you and your staff if you're constantly exposed or somebody turns it on.
Exactly.
And the other thing as well is that if it's a ceiling mounted one, for instance, remember we talked about these droplets need to be a certain size to be aerosolized. They think that it's around 25 microns isn't going to make it up to the light. Yeah. And then it's useless. So then do you put a floor mounted one? Do you put so it's going to be a problem with exposure to it as well. And that takes a lot of serious engineering and a fair bit of money.
I would agree. So we talk about global solutions there with the filtration units. Let's talk more local, working chairside. Do you think two HV evacuators and two big suction units will help? What about Isolite, Dry Shield, I think will help, and rubber dams? Will all of those modalities, do you think, will lower the aerosol, or is that just safe? It's just something we do because we think it may work.
Okay, so let's break it down into the different pieces then. So let's start from inside the mouth and we'll work our way outside, right? Yeah. So if we want to decrease the virality of the plume that we're creating, this is all about the aerosol plume, right? So the first one is we're going to give the mouth rinse, and we know, or we have a reasonable reason to believe that that's going to decrease the viral load of the plume. The second one is the rubber dam. There's decent data out there that the rubber dam is going to decrease at least the bacterial count, and we presume it's going to decrease the viral count in the order, again, of 80 to 90%. When you get down to the high volume suction, again, absolutely, that's been shown to decrease the bacterial count that gets sent out in the viral plume, and we would presume the viral count in the plume um, by a significant amount. When we get to the extraoral evacuators, there's not a lot of data on it.
Yeah.
I would add that in between those two places is where your PPE comes in, right? So you're decreasing the virality, you're decreasing the amount of the plume that gets out with your high volume evacuator and your rubber dam. The person that's sitting in that plume for the period of time needs to be protected. And that's where the appropriate PPE comes in. And then we get to these extraoral evacuators. Will they decrease it? One would presume. Is it going to be a meaningful amount? I'm not sure, only because I think that we're going to be decreasing the amount of virus that's put into that plume with the first 3 steps.
Yeah. I think a lot of that stuff's going to help, and a lot of it we already have. Like I have an Isolite in both my ops for many years. I'm not a huge fan of it, but I may start having to use it more often. So you just talked about PPE to put that in there. Do you think that these N95 masks are going to be the new standard in our world? Because I've seen studies that say the level 3 in a face shield is just as effective. Do we not have enough information at this point? Which would be my guess, but what is your thought on that?
So I think that the N95, or sorry, I was going to say the standard surgical mask, level 3 mask and a face shield, I think is adequate if you're dealing with a COVID patient for routine care, based on what I've read from the public health data. I don't think anybody really knows yet where this is going to fall out with dentistry. And the reason is we're seeing reports out now. There was one I heard from Germany where they said, look, we've had a large hospital system that deals with a lot of dentistry, and we haven't had our dental workers seroconverting in any greater rate than the population. The problem is the population, that the COVID is not endemic in the population yet. We're screening heavily for it to make sure that we're not exposed. And most of the patients do become symptomatic at some point. So I don't think we've had enough asymptomatic shedders in our chairs to say that, yeah, we're really at risk or not. That's the premise to this. The second part of it is, I think that they may become part of it, I hate to say, only when we're creating aerosol, only because I think the next question is going to be RSV, and the next question is going to be influenza, and so on and so forth. So as long as we're dealing with COVID aerosols, I think it'll absolutely be part of it. I really wonder where the regulators are going to fall down on, and quite honestly, the profession. Once we realize, or maybe not even realize, because we don't really know yet, once we have a better understanding of what the risks are we face sitting in that plume every day, are we having higher rates of influenza and we just never realized it, just like we never realized we had higher rates of hepatitis B? Is this going to become the new standard? The short answer is I don't know. The long answer is I think there's going to be a bunch of questions asked at the end of this.
Yeah, good luck finding N95 masks right now. I think, I got one shipment the other day. It was $200 a box for 20. So that's, if it's single use or daily use, I mean, you have everyone in your office is wearing those, that's going to add up. I mean, people are looking at alternatives like the P100 respirators, and they're trying to find different alternatives. I think we don't know. And I think things have changed, and this is where I'm going to end our talk today, unless you have other stuff great information for us. Let's talk about practice management. So pre-COVID-19, we'd compete for PPE with other dental offices, healthcare facilities, hospitals, probably not even physicians' offices as much, because they didn't wear masks on a daily basis. Now we're competing for PPE with every major big box store, every grocery store, almost every industry, and the supply chain is just not there yet. So I'm going to turn this a little bit financial, if you don't mind. What do you think going to happen? And we can only speak what you and I think, obviously, but what do you think is going to happen to dental fees? How are dentists going to get somewhat compensated for this? Obviously, it's part of doing business, but I've seen bills posted online for restaurants to charge a COVID-19 fee. What are your thoughts on that? I have mine. It's this. If this is going to be long term, it can't be a surcharge. If it's going to be short term, I think it would be better to be a surcharge. But what do you think on that? Do you think that's possible? I mean, obviously we're talking opinion. We don't have any facts from anybody. This is just you and I chatting about it. So
yeah. So I think there's going to be two sides to this coin. You know, number one is that will the costs in our office go up? Yes, they will. And there's going to be three parts to it, right? The first is going to be the infrastructure costs, which is, you know, essentially depreciation and carrying costs of doing, you know, closing in rooms, adding doors, changing HVAC systems, or buying air cleaners. I think those things will be spread out over, you know, 7 years. And if you're, you know, you tell me what you spent on this, or maybe you don't want to say what you spent on it, but to say that you could spend $50,000 on this stuff in capital improvements,
easy.
yeah, is not unreasonable. But I don't think you're looking at a $500,000 improvement for a typical office. I think you're talking about a $75,000 improvement, which spread out over 7 years is painful, but, you know, not catastrophic. So that's the first piece of it. The second piece of it is going to be the added PPE cost. And you've already kind of touched on this. The masks right now we're using for a day. There is the option to use reusable masks. There's a lot more PPE coming online. And even though we are now competing with big box stores and the rest, remember, this stuff has been in construction industry for years, you know, for OSHA requirements and all the rest of it. So my suspicion on that part of it is once the secondary producers of it get in line with universal sizing and standards and all that, I think we're going to see a big uptake in the supply chain. In fact, I know that they've already seen it to a certain degree. I've had people on the supply chain side say to me, you know, there's no shortage. The problem is that it's getting the quality and people that can make big enough purchases of it, because you're not buying it.
No, exactly. I bought so I have family that are in the manufacturing world in Asia, and they're furniture manufacturers, and they've pivoted to PPE. And so I bought 1,000 gowns from them, but you have to buy it in certain minimum quantities to get it over here. Now, the bigger problem, I think, is actually getting it here. That has become the bigger problem, is like, so just to talk numbers, on a mask before, the freight used to be, if you were buying a level 3 surgical mask, the freight on it used to be like 3 cents. Well, the freight now is like 65 cents. So the price of the mask, which used to be 26 cents wholesale, and I'm pulling numbers, some of these numbers are not accurate, I'm just using it for example purposes. Well, then now that mask costs 95 cents. Well, you've tripled your cost of that mask. And then by the time it gets to, it goes from a wholesaler to it goes from the manufacturer to the wholesaler to the distributor to you, all those numbers add up. So now instead of what we used to pay for a box of level 3, they're like $45 to $50 to $60. And so and there are more and more players in it. I mean, you know, there are people that are never, like, I had a lawyer contact me, and gracious of his he had a source of FDA approved KN95 masks. I can't get level 3, but these KN95 masks will fit nicely as a level 3. So I bought, but I lucked out. The guy you have to buy them in blocks of 900, but he had sold to a few dentists and he had 100 left. So I'm like, I'll take the 100, and now I'm looking at doing a group buy for the 900, but I'm not, I don't know all the ins and outs of shipping it over here.
There's a short way to say, on the mask piece, I would say, make sure you check the Health Canada website on the KN95s. N95s you're good with, the P100 respirators you're good with on the quality side. The KN95s, there's a wide variation in quality. If you go to Health Canada, they've got an actual approved supplier site. There was a problem recently with somebody doing a massive buy, and it turned out that the quality on them was so low that they couldn't be used.
Wasn't that our government?
Now, though, so here's what I put back to you though. If you look at how much you're going to add on PPE per patient sitting, right? If you and your assistant are using the same mask for the morning, right? And you've got one gown per patient, you know, we're talking about something that's in the $8-10 per sitting, which is not minor.
No.
But it's still not catastrophic. I think, to be honest with you, the biggest hit people are going to take is going to be two pieces. Going back to the economic side of this, one is the long time in between patients for the aerosol to clear, the fallow time. And then the other part of it is going to be the downturn that we're going to see from this. If you imagine all of a sudden dentists all take their rates up by 5 or 10% to account for lower fallow times and increased PPE costs, the public will respond,
Oh yeah, I mean,
especially
some
when
of
they're
them are
feeling the
dealing.
squeeze.
Yeah, I mean they're dealing with it just as we are. I mean, a lot of them are out of work, so it's like it's not an easy conversation to have. My own personal belief is that if you can spread it out over as many things, even if our fees go up a small bit and you're spreading it up over all of it and you're taking some of the quote unquote hit of it, I think that's the win-win for everyone. I mean, you can't expect your patients to pay for all of it, but I also don't think you can expect a clinic to cover all the costs, depending on what our guidelines are. I mean, if it's a single-use N95 mask, well, then my week goes from 5 or 6 masks or 10 masks, whatever, I mean, days you work, to 200 masks. That changes things. So a lot's going to, I think, depend on that, which is...
Yeah, I think a lot will depend on that. But I think as well, I think the market may dictate it as well. I think we're going to see, we will absolutely see a shift in how frequently people are coming in because of the economic impact that's been felt. I mean, people are feeling this badly,
Yeah.
and that's gonna dictate dentist fees as well, PPE aside. We can't have costs that are 2 and 3% above cost of inflation. I mean, we can, but it'll suppress the people's desire to come in even more.
And there's, I this is not my line. Someone said this to me. I think what we're going to have to do as clinicians to protect us and our patients is going to be on 3 factors. There's going to be the science.
Yep.
There's going to be industry pressures, because dental supply companies have products. They've had tons of products, and I think it comes down to your relationship with your representatives. Mine have been very good in telling me that you can buy this, but the college hasn't mandated it yet. So you may want to wait, but the risk you're taking there is by the time you buy it, you can't get it, which is happening. And then the third one is going to be patient perception. I think the 3 of those are going to determine what we as a profession have in terms of PPE. And I'd say this, I had a friend of mine say, well, I'm not buying these filtration units because I don't need them yet. Well, and I said, well, what happens when your neighbor buys them and you don't have them, and patient X walks in your door and says, well, they have all this stuff that works. They don't know the science, but it's going to matter. I think there's going to be a lot of that.
Yeah, I think the regulators are going to set the standard to make sure that the public is safe. And I think as a profession too, that we're going to do what we know to be safe for the patient as ethical practitioners. And then there's going to be what is going to make people feel safe in the chair as well. So I have very little doubt that as a profession, we'll provide a safe environment for people. I think that's going to happen. Whether or not the public will want to see other measures in place so that they feel safe may be something very different. And I think the other thing as well is, what percentage of people out there are just not going to feel comfortable coming into a dental office, for the next 3-6 months, just because they don't, we don't know what people's perception of this is going to be in the dental office.
We don't. Anyways, thank you very much for that. I thought it was a great conversation. I enjoyed learning. I learned some things. I hope our viewers did too. If you have any questions, you can always send it to me and I can forward it on to the right person. You can go to our website, KotechaGPSClub.ca. Once again, Ian, I want to say thank you very much.
Problem.
For all the work. I know not all our viewers may know this, but I know you and your group have done a fair amount of work on this. I've also seen, and not just because I know you personally, I've also heard your name mentioned in various webinars by other people saying the work your group has done. So thank you from our profession to you for doing all that. We appreciate it. And any more questions, you guys can reach out to, you know where to find us. Thank you very much.